So, welcome back to this session on latent autoimmune diabetes in adults. So, this is something we don't see so often, but at the same time, this is prevalent. This is there. There is an entity by name latent autoimmune diabetes in adults. Very important for us to know because it makes a big difference the way how we approach our patient. The diagnosis of latent autoimmune diabetes in adults. This is something which we should not miss in clinical practice because it means a lot to our patient. So we'll just see like what happens to this patient. We will just go through a case history. And I would like to bring to your attention that this latent autoimmune diabetes in adult was for a long period of time, the American Diabetic Association didn't recognize an entity by name latent autoimmune diabetes in adults. But nowadays, we are able to see the terminology in the classification. Though there are lots of literature available, this is not taken into consideration by the big textbooks and guidelines as a part of the classification. But it is very, very important for us to understand because it makes a big difference to the way how we treat our patients with the newer molecules coming up and the way like how we approach our patients. So we'll go back, go to a case history. Mr. Nathan, he's 29 years old. He's insulin resistant. He was like a stout guy who was coming to with all the insulin resistance markers with all this viral tag, with acanthosis, and his BMI is slightly higher. And also he gives a family history. His father is a diabetic. He is taking insulin. He is diabetic for quite some years. And his younger sister is also diabetic. When he came, he was started by metformin and sulfonylurea by another doctor. And he was on good control for 8 months. Now, the reason he visited was he was started on SGLT inhibitors since the control was not good. But at the same time, whether because of the hyperglycemia or because of the introduction of SGLT2 inhibitor, his sugars were very high. In spite of being on SGLT2 inhibitors, his sugars were not under control. At the same time, he developed balanophthitis. So this is how the patient presented. He was requiring unusually high doses of insulin. His blood sugar was controlled with a very high doses, but required quite a higher amount of insulin. When we saw what was the reason that he is requiring so much a high amount of insulin is, two things were contradictory. So he had a GAD antibody positive. We did a routinely like considering his younger age and his father and younger sister being diabetic. So hitch over here is not even father, his younger sister is also diabetic. At the same time, his controls are not good. Even with these medications, for a short period of time only, he was doing well. But at the same time, he was presenting with insulin resistance. So he was presenting with insulin resistance. So typically, if you see, looking at this, he is looking like a type 2 diabetic. But why there is an younger sister diabetic and the individual is also diabetic? That is something which comes under control. Why did he lose the control within 8 months of being diagnosed? So these are the crucial areas which we need to look into this patient. And when we looked at the GAD antibody. Just because he is very young, we looked at the GAD antibody. And we also wanted to see, since he was requiring so much amount of insulin, we wanted to do C-peptide level. So that like if the beta cells are working fine, then we can continue him on metformin and sulfonylurea. If his beta cells are not working fine, then we can put him only on insulin. Probably that is what the idea of asking for a GAD antibody and C-peptide in this patient. But contrary to our belief, like if GAD antibody has to be positive, the C-peptide will be negative, at least over a period of time. It may become negative. But if the C-peptide was positive, we didn't expect the GAD antibody to be positive. So C-peptide is normal. If GAD antibody, we are unlikely to be positive. But in this patient, though he was requiring high doses of insulin, both these things were positive. So where are we headed? So this is looking like a type 1. This is looking like a type 2. So where are we headed? So this is what the confusion happened. So as we see how ADA classifies diabetes is, the disease process in classical type 1 diabetes is autoimmune nature. So when we mean by autoimmune nature, the autoimmune beta cell destruction leads to insulin deficiency. The circulating antibodies are markers of this process. So if there is an circulating autoantibodies which are diagnosed, it could be a GAD, it could be a insulin autoantibody, or it could be an islet cell antibody, or it could be a zinc transporter antibody. So any of these antibodies, if they are present, it shows that the patient has got a type 1 diabetic. So this presence of autoantibodies causes the autoimmune beta cell destruction, which leads to insulin deficiency. Whereas in type 2, we don't see these markers of type 1. We don't see the antibodies. So if type 1 is not there, we take the patient as type 2 diabetic patient. So this is how we classify type 1 and type 2. Type 2, that is beta cell destruction by the islet antibodies, are taken as a marker of type 1. In type 2 diabetic, there are no autoantibodies. They are insulin resistant or not, but no autoantibodies. So we call them as type 2 diabetic.